Hi everyone, we are now on topic 5.5, communicating with clients in crisis. And this unit is going to be just talking about crisis and how we can help our clients deal with that. I'm not going to read through the learning outcomes. They are on Moodle if you want to go through them. The crisis occurs when a stressful life event overwhelms an individual's ability to cope in the face of challenge or a threat. In Greek, it means a turning point. In Chinese, it actually means danger and opportunity. So people respond differently to a crisis. When the tension increases, it causes a major personality disorganization and a crisis state. It's usually short-lived. It's defined in terms of an individual's response to a situation rather than in terms of the situation itself. It exists when a person feels so threatened in a situation that he or she cannot cope with it. Normal resources for dealing with an emergency break down and the individual becomes immobilized. And you are definitely going to be seeing people that will be in crisis. It's an acute normal response to a severely abnormal situation. It's not something that happens every day, out of the ordinary. It's totally throw them for a loop, and they're in a crisis state. It's not a mental illness. It creates a temporary disconnect from attachment to others, loss of meaning, and a disruption of previous mastery skills. It's essential to understand the person experiencing the crisis for a successful crisis intervention. Typically, someone experiencing a crisis needs you to be goal directed. They need direction. During the heightened state of vulnerability of a crisis state, individuals may be more open to making significant life changes. So we have that opportunity with them at that point. There are many different types of crisis. Developmental, maturational. If someone doesn't meet their developmental crisis in Erikson's model, that's definitely a crisis in their life. Situational, an unusual stressful life event that exceeds one's resources and coping skills. Examples: a death, motor vehicle accident, loss of home, loss of job. Most crises are situational in healthcare settings, but they're not defined by the event. They're defined by the meaning to the person who's actually experiencing it. Adventitious or unplanned, usually horrific and beyond one's control. Those are natural disasters, crimes of violence. Catastrophic for large groups of people, much like the fires in Fort Mac. Private usually affects individuals and families. Public, more community disaster. Existential, people are questioning the meaning of life, its value, typically like a midlife crisis. Environmental, we have major changes in the ecosystem, global warming, economic depression, disease outbreaks. Crisis interventions. So how do we deal with that? Systematic approach, very individualized. It meets the needs of the person going through the crisis. Focus on strengthening personal resources and reducing the tension to a workable level, getting them back to where they can actually get footing on the ground and are able to see. Time-limited treatment usually is not a long-term, typically every 4 to 6 weeks sometimes. Goal is to quickly restore individuals to pre-crisis state of functioning. We're going to see a lot of people going back to Fort Mac that are going to be having to go through crisis intervention. The theoretical framework I'm going to look at is Robert's 7-stage crisis intervention model. These 7 critical stages are through which clients typically pass on the road to crisis stabilization, resolution, and mastery. First one is to assess lethality and mental status. Safety. You're concerned about their safety. So treat the medical emergency first, then worry about their mental status. Establish rapport and engaging. You want a safe, non-stimulating environment. These people don't need all the distractions around them. We want to, bring them down. We need a quiet space. Use a directive, calm approach. Active listening skills. Determine their perception of the crisis. Because remember, their perception may not be what your perception would be. Limit number of people involved with the client. For safety reasons, though, you may need more than one professional to help you. Identify major problems. So what's a general outline for the crisis? Focus on here and now. Don't look into the future. That's too much information for these people at this time. Ask about the feelings associated with immediate crisis. Note changes in meta-communication. So watch their verbal and nonverbal communication. See if it's changing. Identify central emotional themes. So use short, relevant questions. Responses should be brief and empathetic. Exploring alternative options and partial solutions. Increases self-efficacy, so now they feel more able to take control. Break down problems into achievable parts, so small goals in achievement of the big goal. Promote autonomous decision making, let them make some decisions, and involve their social support systems. Clients in crisis often have tunnel vision with no possible resolution of the problem. So just if you break it down into little bits, it's much more manageable. Develop a realistic action plan. Prioritize identified problems. Focus is on the present. Best short-term options. Look at the future later once they're a little bit more stable. Introduce immediate small steps, like for the small goals we've already set. Incorporate successful past coping strategies and provide a clear, simple instructions. Develop an action plan. Develop reasonable goals that a client can attain, taking into account their strengths, their values, capabilities, beliefs, preferences, their social support networks. Design achievable tasks. Provide structure and encouragement. So give them time limits and monitor their tasks to make sure they're successful. Encouragement because there's going to be setbacks. Validate their struggle and provide anticipatory guidance. Provide support for families. Families can be the collective group or an individual response to a family crisis. Often is an unstable home atmosphere a family can be in crisis in an atmosphere by changing in roles due to the crisis. So if mom is sick, sorry, that sentence was nasty. If mom is sick, it throws off the dynamics in the whole family. So the family becomes in crisis. May also be legal or safety issues. Individual members of the family deal with crisis in different ways, so you may have to adjust your interventions for the rest of the family members. Developing termination and follow-up. Follow-up provides clients with a lifeline, increases likelihood to follow through with action plan. Verbal and written discharge notes. Provide resource contact information. What strategies can we use to de-escalate a crisis situation? So when you get to a scene and someone's in a crisis situation, unable to, talk down at the time, use an open stance. Brief eye contact. Speak slowly. Use brief commands on simple vocabulary. No sudden movements. Tell them what you're going to do before you do it. Have a calm, reassuring attitude. Now, this is an opportunity for you to be in control. Acknowledge their feelings. Remove distractions, so decrease environmental distractions. Try to get to a quiet space. Keep the client talking and focused on you. Ignore their provocative statements. Allow some verbal venting. Pay attention to personal space. Do not invade their personal space. And set limits if necessary. Crisis can actually lead to a violent situation, and like crisis, it comes in stages where coping mechanisms become exhausted. So the first one is minor motor movements, so clenching the fists or teeth, verbal abuse and threats, then major motor movements, they're pacing, aggression starting to happen, and then they get exhausted. Remember, confusion can also be a risk for violence due to the agitation it brings. Violence can be a threat to the client, a threat to you, or other clients. And your safety is utmost importance. So what do we do for these people? Find a calmer, neutral, accepting personal space when you see agitation rising. This should be also a safe environment for everyone involved, including yourself. Approach clients with caution. Do not startle them. Avoid escalating the situation by asserting your authority, provoking, or becoming emotionally hurt and retaliating. You have to remain calm and collected during these situations. Identify and reduce possible stressors and triggers. Provide alternatives to escalation. Watch their nonverbal communication very, very closely. You want to use a low, calm tone of voice. Avoid challenging. Be firm but respectful. Remove dangerous objects. And be aware of exits for yourself. If you need to get out of the situation quickly, you need to know where to go. Safety is a top priority. And that's why moving the client to a more private space is absolutely necessary. Family responses to crisis. Each member of the family can have any of the symptoms of crisis mentioned earlier because they're going to interpret them differently. Due to the possibility of confusion, you may need to repeat and reinforce information given. Another crisis is suicide, which is happening more and more. Ultimate personal crisis. It does not have a good ending. Evaluate imminent risk. Take all suicidal statements seriously. Verbal and behavioral indicators. So verbal, I don't see anything good in my life. They'd be better off without me. And behavioral, they're starting to give away their possessions. So these are just little clues of what they may be thinking. High risk factors: immediate stabilization and safety of the client. A suicidal person may harm themselves, take part in reckless behavior, withdraw from everyone, give up on their hobbies, misuse alcohol and drugs. And again, you may not notice any of these. A family may not notice any of these. We just didn't see it coming. Ask them directly. Are you thinking of hurting yourself? How often do you have these thoughts? Have you made a plan? If so, what's the method? How will you get those materials to complete that task? What do you hope to accomplish? You determine their level of hopelessness. Is death really the ultimate goal? Timing of the suicide, right away or in a month? Who is your support system? No support. If they have no support system, it's a much higher risk. Remember, the youth, the elderly, the middle-aged individuals are at particular risk for suicidal thoughts. It's a growing trend now, though, that our elderly men are committing suicide more often. Disaster and mass trauma situations definitely cause a lot of crisis in people. A large-scale community disaster, such as a major fire, requires disaster management, then emergency rescue services. And a lot of you have just now lived through this. So 3 phases: impact, heroic rescue honeymoon, and crisis intervention. So the first 2 phases address the event itself rather than the psychological needs and responses of those experiencing the disaster. You got to fight the first one. You got to fight it, right? You got to throw everything at it. Involves all the disaster management and emergency relief efforts of everybody. Phase 2 is often called the honeymoon phase because the community is hopeful and pulls together in a heroic rescue of the town. And you're going to see that as it starts going in Fort Mac. The disaster and emergency management agencies focus on public safety, on locating disaster shelters, temporary housing units, and medical care for survivors and their families. And then 1 to 4 weeks after surviving the loss of home, neighbors, and their community, phase 3 can begin. Now they have to rebuild, right? Crisis incident stress debriefing. Now I'm not sure if any of you actually went through a crisis incident stress debriefing, but you probably should have after you've been fighting fires. Designed for those directly involved. It's guided, highly structured, confidential. It's a great time to actually learn a lot from how you managed and how you coped. Face the facts and then the feelings associated with critical incident. Useful for families who have witnessed a family tragedy. It's a mutual sharing and increases understanding of what's happened. PTSD is an emotional illness that is classified as an anxiety disorder. Now, this is going to concentrate on clients who have PTSD. However, you have to be aware that we are, as healthcare workers, we are all at risk for PTSD. So never be afraid to ask for help if you feel that you're not being able to cope. Associated with frightening, life-threatening, or otherwise highly unsafe past experiences, women are twice as likely to experience PTSD. So what are the symptoms? Recurring memories of the traumatic event, avoidance of places, people, and experiences, numbing of emotional responses to emotional situations, sleep disturbances, limited or poor concentration, irritability, unexplained anger, blackouts, poor memory, or hypervigilance. Those are just some of them. Now, the next 3 slides I'm not going to read because you can read them yourselves and work through them. And then after those, I have put in, I'll just flip to it. There's strategies, just for fun review questions. So work your way through them and just see how much of the information you've retained. And it'll also help you for the final exam as well. Anyways, on to Unit 6.